All right. Well, good evening, everyone. Thank you for joining us today. Cassie, are we good with the waiting room? Is everybody in?
We're good. There's a couple people that are trickling in a little bit here and there, and I'm admitting them as they come through.
Okay. Well, we'll just go ahead and get started. Thank you all for joining us tonight. We really hope that you enjoy the back to school webinar and that you learn some things and get any questions that you have answered. So to start tonight, I'll be our host. My name's Amanda Mitchell. I'm the Executive Director of Epilepsy Alliance, Louisiana. And just to go over some of our logistics, we do ask that you remain muted unless you are asking a question. If you would like to ask a question, please go ahead and you can put it in the chat or you can raise your hand and we will do our best to get your question answered as fast as possible. Just so you know as well, this meeting is on Facebook Live and it is being recorded. And then that recording will be made available on Epilepsy Alliance America's website. As I mentioned, I am from Epilepsy Alliance Louisiana, but this presentation was made possible in partnership with Epilepsy Alliance America. Epilepsy Alliance America is dedicated to supporting those impacted by epilepsy in our local communities. It was founded in 2018 by 8 leading grassroots organizations. And we are very proud as Epilepsy Alliance Louisiana to be part of the 8 founding members. And so before we get any further, I want to take a minute to introduce our presenters tonight. Our first presenter is Miss Rachel Honore Young, who is a pediatric family nurse practitioner in the Our Lady of the Lake Children's Hospital. We also tonight have Dr. Yash Shah, who is the clinic director at Our Lady of the Lake Children's and is a board certified neurologist. We also are very excited tonight to have Mr. Braylon Brown and his mom, Dion, who will wrap up the rest of our webinar, sharing a little bit of a personal story of how this relates to students with epilepsy. So we're going to start with you, Rachel, and thanks again for joining us.
Thank you. Thank you. Good evening, everyone. So as she's mentioned, I'm Rachel Honore Young. I'm the nurse practitioner here in the clinic at Our Lady of the Lake Children's Hospital. And I'm just gonna kind of go over some back to school seizure preparedness items with everyone tonight. So thank you for having me. Next slide. All right, so here's a quote from Mr. Alexander Graham Bell that states, "Before anything else, preparation is the key." So we're going to talk about a little warrior named Duncan and how Duncan's family can prepare him back to school with the appropriate seizure action plan, accommodations, and things like that that he may need. And so a little bit about our little boy, Duncan. He's a little 8-year-old boy who first started having seizures at the age of 2 years old, secondary to brain malformation. And now Duncan's in the 3rd grade, and he has several types of seizures. The first type, he has generalized tonic-clonic seizures, and these seizures sometimes come in clusters over 3 to 4 minutes, maybe within an hour, and these are pretty frequent, occurring once a week. And he has a second type of seizure, which are generalized tonic-clonic seizures. These are not as frequent, kind of happening once a month, lasting maybe 2 to 3 minutes, but sometimes it can last up to 5 minutes. And the third type of seizure that he has or staring episodes, also known as absence seizures, and these occur a few times a month. So 3 different types of seizures. Something's happening every week, maybe every other day or so, but how can we prepare Duncan to get back to school? So for the first 2 types of seizures, these are a little longer, so they're requiring rescue medications, whereas The third type of seizure may not require rescue medication. And so we want to know, okay, what are his triggers? Some of his triggers are sleep deprivation and flickering lights. So what can we do to keep Duncan's family safe, or to keep Duncan safe and happy at school? So there's a few things that we can do to customize or individualize Duncan's plan at school. That includes general precautions, safety with exercise and sports, special accommodations, and the big seizure action plan. Next. So because we already know what type of seizures he had, there are some general precautions that we want to make sure are in place, not only at school, but also wherever, if he's at camp after school or camp during the summer, things that he's, when he's with people most frequently, need to know about these precautions. So some things, we know that flickering lights can trigger his seizure. So we want to avoid strobe lights. So if there's an activity at school that requires lights to be flicked on and off, or strobe lights, we need to make sure that he's protected from that, so that he does not, or so that a seizure isn't triggered. Because of those tonic-clonic seizures, we want to make sure that, or even absence seizures, that he avoids heights at all costs. If he was to happen to have a seizure and fall to the ground, that could be very traumatic. We want to limit heat exposure, and of course, limit that screen time. Things that can, again, trigger or cause traumatic recourse if he were to have a seizure while doing those things. Next slide. Perfect. And so when we talk about sports, there are a lot of kids, they want to participate in multiple different sports at school, some more safe than others. But there are different groups of risk or sports, depending on the risk, where they have no significant or additional risk, up to more high risk activities like climbing, aviation, water sports. So when it comes to water safety, we want to make sure that there's proper supervision. If they have to take showers at school or swimming at school, if they have an after school activity where they go swimming, we want to make sure that they're supervised at all time. And of course, at home or at grandma's house, want to make sure that they're taking showers. And I always tell my kids, my older teenagers too, hey, if you want to take a bath, mom or daddy got to be there, because we want to make sure we provide an appropriate or safety measures for that child. Next. And then, of course, after 12 months of seizure freedom, they are able to participate in all of those different activities. Next slide. Okay, so here we talk about special accommodations at school. I'm gonna kind of highlight or talk about each one of these. The first thing is bus safety, but not only bus safety, safety at school. We want to make sure that the bus driver or anyone, any personnel who is familiar with this child, who is around this child most frequently, have a copy of the seizure action plan. And we'll get it again, I'll get into the seizure action plan shortly. But we also want to make sure that schools are aware that an unlicensed individual, they are able to administer rescue medications for a child who is having a seizure. We just want to make sure that they're properly trained, and that can be done through the parent, or just, some of the, like Valtoco, some of them, they provide educational pamphlets that tells them how to administer that medication. And we want to know when to appropriately and administer that medication. And so I'm going to skip over the seizure action plan for just a second, because I want to talk about a 504 and IEP plan. These are going to be vary from state to state. The type of accommodations that are provided vary from state to state, school to school, public school versus non-public school. But the IEP in particular is a plan that is special, that provides specialized educational needs for a child. So it outlines specific goals and objectives for them to receive specialized care at school, whether it's a therapy. Some patients have epilepsy, that are refractory epilepsy, that may require them have cause them to have some debilitating things, and they require therapies. Whereas the 504 plan, which I think a lot of patients have, is more so for accommodation. So a child with absence seizures may need extended time, or any type of seizure for that matter. They may need extended time for test taking or for homework. So those are the two different things that you want to talk to your school about. Get with people appraisal, whoever does those type of evaluations in the schools, to see which one is more appropriate for your child. I know here, and Stephanie, don't quote me on everything, but I know Stephanie, who is one of our advocates here with the Epilepsy Alliance, she has gone into the school sometimes with the parents to kind of help them navigate that, to make sure that their child is receiving the appropriate accommodations at school. So again, just check with your school to see what's more appropriate for your child. And then we move on to the seizure action plan. Next slide. And so the seizure action plan, every person with epilepsy should have some type of rescue therapy, whether it's Diastat, the Klonopin tablets, or some type of rescue nasal spray. And every child should have a seizure action plan. And the purpose of that seizure action plan is specifically for school teachers, nurses, coaches, or whoever that child is with the most, whoever's supervising that child. It gives them a guide to allow them to know when should they call, for rescue or for 911, or when should they use the rescue medication, or what should they do if that child has a seizure, what triggers that child may have. So, we typically tell patients like, hey, make sure you have a couple copies of this, or parents have a couple of copies of this. Keep one with you, mom. Make sure the child has one in their backpack. One should be kept in the school with the school nurse. There are some schools in our district, not sure, other places, that may not necessarily have a nurse. There should be some type of medical log and file at school where these seizure action plans can be placed. You can easily get one from off the Epilepsy Alliance of America website. This is where I get it from my patients. I generally do most of the seizure action plans for patients in our clinic. And I like it too, because it's a PDF form. You can go in and type in it, print it out, and sign it. But this is something that you would get from the neurologist or whoever's managing that child's epilepsy. Next slide. And so on a seizure action plan, there are several things on here that, and it's a very quick but detailed form that tells you, again, outlines that first aid of what to do if a child has a seizure. So the standard care that's needed for all patients, I generally say yes for all of these things. We should make sure that they know to time the seizure. Time in the seizure will allow us to know, okay, well, hey, it's at 3 minutes. Should we be using the rescue medication? It's at 5 minutes, whatever is indicated by your provider. As far as the duration of the seizure, when to use that rescue medication. Make sure we're keeping that patient safe, protecting their head, not restricting them, allowing them to have the seizure, and making sure we stay with that person to continue to monitor them, and keeping record or a log of that total event. And I'll kind of back up, not really sure how the schools, if they are able to do this in school, but we do tell parents, hey, if that child has a seizure, if they're protected, record the seizure if you can, because that gives us providers more information of what that seizure actually looked like. Next slide. So here's an example of the seizure action plan. This is Little Duncan Warrior seizure action plan. Again, very simple yet detailed enough for those individuals to know what to look for. Again, sometimes we may not necessarily know what that child's triggers are. A lot of times it could be, illness, fever, sleep deprivation, flickering lights. So we want to annotate that we do annotate that on that seizure action plan. And there's a little pictures of what the different types of seizures may look like. We'll, check those boxes. And then further down on the seizure action plan, we do also annotate when to provide that, when to use that rescue medication. Here for Little Duncan, it says for seizures greater than 3 to 5 minutes. One thing that we're kind of seeing here in a couple districts around us, that now they don't want that range of time. They want to either see 3 minutes or 5 minutes. So we're having to be more specific on these seizure action plans when to administer that medication, and when to call for help. And then the last thing, again, I just want to reiterate, keeping the seizure action plan with you at all times. If you do not have one, make sure you reach out to your provider, whoever's managing your child's epilepsy, to get one of these seizure action plans, again, to keep with that child at all time. Put one in a central location in your home. If you have a nanny, make sure they're aware of it. Make sure that they feel comfortable and that child feels comfortable as well. We always, want to make sure that that child's included as well, so that they are aware, hey, I have a seizure action plan in place. Because sometimes I have kids who are more, advocates for themselves. So make sure your child knows what's going on and the purpose of this seizure action plan. And also, if they're going to camps over the summer, make sure that they have this seizure action plan along with whatever type of medication that they use. And one other thing I'll point out, it does specify like where to administer the medication. Sometimes someone who's unfamiliar with the medication, they may not know, okay, well, does this go, the rectal or intranasal or oral, because there is an oral tablet that is also used for to stop seizures. So we also want to make sure that that's appropriately checked off on the seizure action plan as well. And that's it for that.
All right. Thank you so much, Rachel, for helping us, understand how we can better start the year. And it looks like I didn't see any questions in the chat. So we will go ahead and move on to Dr. Shaw. As I said, Dr. Shaw is a pediatric neurologist and epileptologist here with us in Louisiana, and he is the section chief at Our Lady of the Lake Children's Health. So I'm going to go ahead and stop sharing this slide so that Dr. Shaw can share his.
Perfect. Great. So thank you so much for the introduction, Amanda, and thanks Epilepsy Alliance of Louisiana and Epilepsy Alliance of America for this invitation. Give me just 1 second. I'm making sure that my presentation is seen appropriately. Perfect. So are you guys able to see my screen? Just making sure.
Yes, we are. Dr. Shaw, I don't know if it's looking different for you, but Zoom seems to have made an update since the last time we presented, but we can see everything.
Awesome. So let me move to the next slide. So just to start beginning, I want to touch base on two main topics here. One is accommodations and the second is rescue, because these are the two most important things in epilepsy that are challenging at times and very important to understand, so that we can better manage epilepsy overall. So when we think of epilepsy, seizures are the first thing that comes to our mind. But as this slide shows, epilepsy is much more than the seizure. Children with epilepsy often face a wide range of challenges. For example, around 20 to 50% of the kids with epilepsy have attention deficit hyperactivity disorder. 20 to 30% of the kids with epilepsy have autism. Developmental delays are also very common. Anxiety and mood disorders are extremely common with epilepsy. So as you see, it's the tip of the iceberg. That brings to our next slide, why we need accommodations. So based on these factors, based on these comorbidities, I would like to tell my patients that epilepsy is an umbrella term, where seizures is one of the side effect of epilepsy, but there are several other things which goes along with epilepsy, which is when you have seizures, it can affect multiple parts of your brain. For example, if it affects the part of the brain which affects your memory centers, which is hippocampus, you can have memory issues. You can have struggle with retaining information or recalling what you have learned in school. Second is if it affects the frontal part of the brain, which is mostly involved in planning, organization, problem solving skills. So if that part of the brain is affected, then you can get issues in those particular skills. So that's the reason why accommodation becomes really important. It's not just it becomes essential, not just helpful, but it's very essential to get some accommodations when you have epilepsy. So diving deeper into accommodations, it can affect social, it can affect academic, and it can affect other specific academic difficulties that you can get with epilepsy. So firstly, let's talk about social consequences. Children with epilepsy often struggle with fear of negative perception from peers. This fear can lead to difficulties making new friends, which can in turn lead to emotional problems in the school, including mental health issues. And over the time, these challenges can erode child's self-esteem and making it even harder for them to engage socially and participate fully in school activities. Next, talking about academic impacts, seizure along with their side effects, especially with this anti-seizure medication at high doses. For example, if the child is on Depakote or topiramate, those are on high dose of seizure medications, can affect a lot of side effects. For example, sleepiness, lethargy, tiredness, memory issues. So those are important things to keep in mind when we think about accommodations. Furthermore, the level of understanding and expectation from the teachers can greatly influence how well these students can perform academically. And lastly, we must consider specific academic difficulties. Some kids can just struggle with mathematics because some of the focal seizures affect that part of the brain which controls your area of the brain which impacts learning, especially mathematics or spelling or reading and comprehension and word recognition. So having said that, what we can do in school to improve their management strategies. So first and foremost, encourage participation, include students in all the activities and avoid unnecessary restrictions that might limit their involvement. Provide clear factual information about the epilepsy and foster empathy among peers to understand their seizures and reduce the stigma. Other thing we can do is empower students, involve students in discussion and give them leadership roles to boost their confidence. Peer support is extremely important. Buddy systems and encourage cooperative learning to ensure consistent peer support. And last but not the least, with breakthrough seizures, the kids can have absence in the school. So you have to allow flexible participation when they return. And this something which we can put under school accommodation. And this, I always emphasize our patients and their families to discuss with their providers to make sure that they include in their either in their IEP or in their 504 plan or additional letter from the doctors, which can help getting these accommodations in their in the school. Next is academic strategies. So talking about academic strategies, individualized instructions, which we can develop personalized learning plans, including seizure action plans that Rachel discussed. Classroom accommodations are extremely important, where there can be simplified instructions can be used. Flexible assessment, child should be given extended period of time for the assignments. They should be allowed more breaks during the test to reduce the cognitive strain if they are suffering for significant learning issues from epilepsy. And last but not the least, utilize memory aids, break task into smaller steps, regularly review key concept to help their retain information and focus. So these strategies ensures that the students with epilepsy can succeed academically while managing their unique challenges. So now I would like to switch the gears and talk about some definitions to understand why we use rescue therapy and how we use rescue therapy. So I want to give you an analogy to understand this particular concept. So epileptiform discharges are discharges that we see when we do the EEG on the kids who have epilepsy, where we see some sparks. And think of these sparks as a brief flicker or flame in the forest, which are momentary, which are small, and they don't catch fire, but they tell us that this particular person is at high risk of having seizures by looking at their EEG, by looking at their background activity. Now, if these sparks gets more and more, then it kind of gets into a campfire where it suddenly flares up and spreads, and it becomes a seizure, which lasts for less than 3 minutes. And it can happen once in a while. We call it as a breakthrough seizure. However, if the child gets 2 or more seizures, we call it as epilepsy, because those kids are at high risk of having seizures. And there are several triggers which can actually make their seizures more often, which we'll discuss in our next slides. And last, not the least, status epilepticus is a massive uncontrollable blaze where your seizures keep ongoing more than 5 minutes and doesn't stop, and you will require rescue medication. So why it's important to discuss rescue medication is because those kids who have seizures more than 5 minutes can sometimes can have brain damage, or can have issues with your respiration, or can have issues with your cardiac system. That's the reason it's extremely important to discuss about rescue therapy. So what is rescue therapy? This is the therapy which we use it for to stop the seizures. Either it's cluster seizures, the seizures which happens back to back to back, or the prolonged seizures, or status epilepticus, which are seizures more than 5 minutes. It's used to prevent seizure emergency, and the rescue medication generally do not replace routine medications to treat the seizures. So person has to take regular medications if they have epilepsy. Rescue medications are just on the top of that to stop their seizures if it's prolonged. Rescue medications are as needed medications. They are created to be used in school, outside clinic, or ER, or in the hospital. Currently, we have 3 FDA approved rescue medication in children to help control their seizures for prolonged seizures. So when do we use rescue medications? So as we discussed, if they happen back to back, if they are prolonged, or if they are going into more than 5 minutes, which is status epilepticus, or sometimes at high risk time when we know that this kid has some risk factors. For example, if the kid is having fevers, sometimes we use rescue therapy as a bridge therapy to make sure that they don't develop seizures. So this is a controversial topic about cluster seizures because various people use this different definition. But to me, if the child is having more than usual seizures back to back, those are known as cluster seizures. Either it can be more than 3 seizures in 24 hours, or it can be more than 2 seizures in 24 hours, or it can be more than maybe 2 seizures in 6 hours. So they are acute, repetitive bouts of seizures. May have sometimes the warning signs. Some kids may feel that their seizures are going to come. They may feel a little dizzy. They may feel a little tired. They may feel some tingling and numbness in their extremities. So they may have some warning signs before they get seizures. But sometimes, most of the time, they may not. And in between, important thing to understand is that in between cluster seizures, the child can come back to their normal self. Unlike status epilepticus, where they don't come to their normal self. So again, there are status epilepticus are 2 different types. One is convulsive and second is non-convulsive. Convulsive type of status epilepticus is seizures which continues for more than 5 minutes. And they are having tonic-clonic seizures, or they are having stiffening seizures, or they are having seizures with one side body jerking movements, or one-sided stiffening, or facial twitching. So there are several different types. And the non-convulsive ones are actually difficult sometimes to understand because they may not do anything. They may just be staring in the space, or they may not be responsive for more than 5 minutes. And in those cases, sometimes we may require to do some more investigations to find out if they are having non-convulsive status epilepticus or not. So why do we need rescue therapy? So we just discussed about this, but again, just to repeat, seizure cluster can sometimes progress into the longer seizures. Repeated seizures can have very high morbidity, can cause injuries, can also sometimes cause mortalities if it's not controlled. can have higher rates of emergency department visits. So we want to prevent that and hospitalizations. That's why important to use rescue therapy. And patient and caregivers experience negative quality of life if the child keeps having prolonged seizures. Who all are at high risk of having cluster, prolonged seizures, or status epilepticus? So first of all, those kids who have difficult to control seizures, for example, if they need 2 seizure medications or more than 2 seizure medications, those are drug-resistant epilepsies. Epileptic encephalopathies, for example, the child has severe developmental delays or Lennox-Gastaut syndrome or Dravet syndrome. Those are difficult to treat seizures. Multifocal epilepsy, that means the seizures are coming from different parts of your brain. If you have history of brain infections like meningitis and encephalitis, traumatic brain injury, if the child had hypoxia at the birth or some trauma at the birth, that increases your risk of having prolonged seizures. And we'll talk in detail about seizure triggers and higher seizure frequency. So if the child was diagnosed initially and they had more seizures initially, then and at early age, those kids are at high risk of having cluster seizures or prolonged status epilepticus. So what are seizure triggers? Very important to keep in mind, especially when we start school, because sometimes in teenagers and older kids, school stress, homework, sleep deprivation is one of the biggest trigger for seizures. Illness, both with and without fever, can trigger seizures. Flashing bright light that Rachel discussed early on. Drug use of cocaine and other recreational medications, recreational drugs can trigger seizures. Stress, both physical and mental stress can trigger seizures. Anxiety is one of the common cause of seizure trigger. A lot of girls around the time of puberty or after puberty and adolescence, they get more seizures around the time of their period. So very important to recognize that. Dehydration, not enough fluids, especially in the summers, especially when they're playing out in hot sun, can trigger their seizures. Obviously, missed medication would cause you to have more seizures, and head injury puts you at high risk. That's the reason why initially we discussed about those sports activities where you have to wear proper gears to make sure that you don't get head injury, because on the top of epilepsy, if you get head injury, you have a high risk of having prolonged seizures or status epilepticus. So what are the medications that are approved for a rescue? So currently FDA approved medications: diazepam rectal gel, midazolam nasal spray, diazepam nasal spray, and some of the off-label are buccal midazolam, clonazepam, and VNS, which is vagus nerve stimulator. So what will make your rescue medication ideal? So think about, if you take something orally, it takes time to go into your system. It has to go to your esophagus, then it has to go to your stomach, then it has to go to your intestine, and then it gets absorbed in the body. So those are not ideal because it will take up to 60 minutes to reach your body. So what we need is either rectal or intranasal or intravenous route to help stop the seizures if they are lasting for more than 3 to 5 minutes. Because they are fast acting. In fact, the intranasal are faster acting, which within less than 3 minutes, it starts acting and helps stop seizures. Even the rectal takes 3 to 5 minutes. Intravenous, yes, those are ideal, but we can't use it in a school setting because it's dangerous to use intravenous unless and until you are in hospital or emergency room. So which one to choose? So right now we have total 3 options. So diazepam rectal gel. So this is approved for kids 2 years and above. And we can repeat one dose in 4 to 12 hours. So if they had one seizure and then if that does not stop their status epilepticus, you can use another dose to help stop their seizures. What are the pros? It helps in it's easy to dose. It is very long. It's used since many years. Very rapidly absorbed, and can be given in conscious and unconscious patients. The only problem with this is that, especially in the older kids, it's social implications. People may not like deliver rectal medication, especially in the school settings. That's where we have diazepam, which is a nasal spray. Unfortunately, it's only approved for 6 years and above. There are several studies going on right now for kids 6 years and below, but right now it's 6 years and above. It's a very easy to use, and we'll discuss in detail about that. Again, same thing, you can repeat the dose one more time in 4 to 12 hours if the seizures are still ongoing. Yeah, there are no particular disadvantage of this. You just have to make sure that the child is having open nasal passage, but otherwise it's very easy and safe to use. So talking about rectal diastat, as you see on this particular screen, it is a injection syringe like this, and it should show this green line here, which shows that green ready band label. And the dose window is displayed here. So make sure that what's written on your seizure action plan is matching your dose display window here. Make sure that you store it at around 25 degrees, especially here in southern part, Louisiana. If you keep it in the vehicle, it can sometimes get deactivated because the temperatures are in 90s and 100s. So make sure that you keep it below 80 degrees. How to administer? Very easy. Put the person on their side where they can't fall. Get the medicine, get syringe, and make sure that the pin is attached to the cap, and then push up the thumb and pull to remove the cap. And after that, lubricate the rectal tip with the lubricating jelly, and turn the person on the side facing you, and then bend upper leg forward to expose the rectum, and then separate the buttocks to expose the rectum, and gently insert the syringe tip into the rectum to administer this. Then you count 3, 1, 2, 3, loudly for 3 seconds. And within 3 seconds, gently pushing a plunger until it stops, until the whole dose is given. And again, same thing, slowly count 3 before removing the syringe, and then that's it. And then wait and watch. Within a few minutes, the seizure should stop, less than few minutes though. The next is Valtoco nasal spray. This is one of the easiest thing to do. You have to open the blister pack, remove the nasal spray, and hold the nasal spray device. And then once you put it in the nose, then you insert the tip of the nozzle into the one nostril until your fingers on the either side of the nozzle are against the bottom of the nose, and then administer it. And it takes less than 3 seconds to completely administer the full nasal spray. So similar to Valtoco, which is nasal diazepam, we have nasal midazolam, which is also approved for kids who are 12 years and above. It's exactly similar like Valtoco. It only comes in one dose, so it's easy to dose for the patients who are about 12 years of age. Sometimes we do experience rectal diazepam shortage. So you can discuss with your provider about clonazepam. Clonazepam wafers are something also which we can use if we don't have other medications available. The clonazepam wafers, those are dissolvable pills that you can put it in the mouth. You use your dry hands to put this particular oral dissolving tablet in the mouth between the cheek and the teeth. And make sure you use the other side, because sometimes with the seizure, as you know, there's a lot of salivation and frothing. So try to use the other side where the froth is less, and so that it easily gets absorbed in your system. So again, Epilepsy Alliance of America has lots of videos in English and Spanish to understand how to administer all these rescue medications. So just to conclude, discuss with your healthcare provider about school safety. And again, remember, epilepsy is more than just a seizure. As we discussed, ADHD, learning issues, anxiety, stress, those are all can be associated with epilepsy. Make sure you get your seizure action plan. If your provider is busy, make sure you get your seizure action plan, and make sure you get it signed from your providers whenever you go and see your provider. Don't wait for your school to begin. Make sure that you have seizure action plan always ready with you all the time. And again, make sure that you have rescue medication available at different places. Like, let's say if your child is at 3 different places, lives in father's house and or mother's house or in school. So make sure you have 3 kids available. So yeah, that's what I have for today. Thank you for listening and joining.
Thank you so much, Dr. Shaw. And I'm really glad you mentioned trying to get your seizure action plan done early. I know for us in Louisiana, school has already started, but I was talking to some of the other neurologists who were saying that it could take them up to a week or so to get these seizure action plans back to families because of the number that they get at the beginning of the year. So it may be a good idea to go ahead and put it on your calendar for, June or July for next year to send in that request a little earlier. So up next, y'all, we have Mr. Braylon Brown, who is a young man who lives with epilepsy, and he is going to share with us his experience and how he advocates for himself in school. So Braylon, do you want to go ahead and come onto the screen while I get your presentation up?
Yes, ma'am.
Okay. How are you tonight, Braylon?
I'm doing good.
Good. Well, we are so excited that you joined us. And so, like I said, I will help you with your slides. Y'all, Zoom is doing something new that I've never seen it do before for presentations. So let's make sure. Oh, can everyone see the Braylon slides? Okay, we'll go ahead, Braylon, when you're ready.
Okay. Hi, everyone. Today I'm gonna. I'm sorry. I'm so nervous.
That's okay. Just take your time.
Okay. Today I'm going to be explaining like my experience with getting a 504 plan, like to help me in school, and also why I think that that children or parents watching should get one for their children. Okay. Starting off, what is a 504 plan? A 504 plan is a type of plan for students with disabilities who need some adjustments to the learning environment to help them meet their needs in the classroom. In my experience, this has been like I've needed a computer since my handwriting has been illegible to most teachers. So yeah, why you should get a 504 plan. If your disability hinders you from doing a certain task in school, then a 504 plan will help you by making the task easier for you. Like again, how I was saying, like with me, my handwriting illegible. So just so that the teachers could grade it, I've needed to use a computer. For, and I've been using a computer for like the past, since 7th grade. I'm not gonna say 2 years since the year just started. Okay, fears you might have about getting a 504 plan. Okay, so the teacher might not listen to you. You may feel excluded, and kids might make fun of you. 2 of these were very apparent for me. Like, I have had fears that teachers would not listen or just wouldn't care if I told them I needed to grab the computer. And if I told them I needed to grab the computer, because I've noticed that like very few teachers will even ask about things like that, no matter how bad anything is, or even if you already have one set up with the school. And then feeling excluded. Before I had my whole computer situation, I used to have this like paper with certain types of lines for me to write on. That would help me, and I never used it. So that because I felt because I never used it because I felt different from the other kids who were just writing with normal paper, and I'm writing with something for like kids that can't write well. So I didn't want to use that and feel excluded for years. And then kids making fun of you. Like, I have somewhat had, this has been kind of the opposite for me. Like, I feel like more so kids have been jealous since I've been using a computer, but I understand like how kids might make fun of you, like saying that you, like, if you need this, like, they're gonna make fun of you since you can't do what they can do. Okay. Why you should face these fears? Like, okay, so in my experience, why you should face these fears? You can do better in school. You don't have to do an assignment multiple times, and you can learn more about what helps you. Okay, so for me, this is definitely, my 504 plan has helped me do a lot. Has helped me do better in school because I get because another part of my 504 plan is I get notes from the teachers, which if it's something like a study guide that already has answers like it has fill in the blanks, sometimes I'll write on that because like how am I going to copy a whole PowerPoint page before the teacher clicks off? I can't do that. So yeah, and I've been given notes from teachers that I've had over the years just so that I can have notes to understand. And then there have been times where then for not having to do the assignment multiple times for not since my handwriting has been bad, sometimes I've had to redo assignments like the teachers have told me I need to redo this since they couldn't read it and after learning more about what a 504 plan is and how it can help me, I've learned what I need on like a daily basis to help me as a person. Like cause I didn't know that, cause say for instance, you're like, you want to get a job later in life. Some things that you might have had problems with as a kid, you might still have problems with them. Because like me, I've had the problem with my handwriting for years. Like since I got into school. And I know that I know that now I probably should I probably am going to need to use a computer for things like writing stuff down, which will make life easier for me. Next slide, please. Okay, here's some advice that I want to leave y'all with. For any parents and any kids, don't wait too long to get your 504 plan and make sure that the teacher understands it. Those two kind of go together. And then think more like don't think more about what you need than what other people would think about you. Because like for the don't wait too long part is like I waited until like 7th grade to start using a computer, which I am lucky I got that early on. Cause like I'm in high school now. If I started trying to use the computer now, it probably wouldn't work out so well for me. Like I probably wouldn't be able to use the computer since I had waited too long to try. And making sure the teachers understand. It's because like I've had like only one teacher who has actually asked about it. Who was actually like 1 to 2 teachers who have actually asked about my handwriting and just gave me a computer first and just let me use a computer instantly. Like others, I've had to resubmit. I'd have to like give. My mom has had to like email the teachers about this for more of my teachers for more teachers than I can think of probably. And then and then like think about what you need more than what others think is like if you just are thinking about what others think, then you're not going to be able to do what can help you in school. So and that can really affect you in the long run. Like you could be trying to get a job in the future and like, or actually just trying to apply for college, them seeing your grades, like thinking, they're not good at this subject. But no, really, it's just you're good at it. It's just you didn't have everything you needed to help you excel. Thank you.
Thank you so much for sharing your story, Braylon. You always do such an amazing job at being an advocate for other kids with epilepsy. And we're always so proud of you for sharing, you know, what you've done and how it's helped you. That brings us to kind of the end of the formal part of our our webinar today. So I do want to see if we have any questions. So far, Braylon, just so you know, we don't have any questions, just a lot of comments about how awesome you are. And thank you for sharing again with us today. So are there, though, any other questions for Braylon or Dr. Shaw or Rachel? So I did see there's one for where we can access the recorded meeting. Lisa or Cassie, I think you said it would be on Epilepsy Alliance America's website after it's ready.
Be on Epilepsy Alliance America's website, our YouTube channels, and we will email everybody who was registered for tonight and let them know when they are available, either tomorrow or Monday.
Awesome. More thank yous for Braylon. And that is it. Okay, so I'm gonna just, let's see, share our last couple of slides.
Amanda, there's one question about nasal rescue meds.
Oh, sorry, I missed that. Okay, hold on.
No, it just came in.
Okay.
I think it's around coverage and the cost. Dr. Shaw, I'm not sure if you're able to see that question. I've asked our son's neurologist about rescue meds. He said it's very expensive and often not covered. Want to know about the accuracy of that, which we realize will depend on insurance coverage, and also what is the shelf life of the nasal spray?
Yeah, no, that's a good question. We get this all the time. Lot of times the insurance company denies it based on how it's written. So we have to be very specific. Sometimes if it's written just for seizures, they may not cover it. You have to make sure you put status epilepticus or seizures more than 5 minutes, or cluster seizures. Right now, currently the insurer approval is that if you have cluster seizures or if you have seizures more than 5 minutes, you can get it approved. Second is that yes, it is costly. I'm not sure the pricing, but what I've heard from the patients is it can sometimes cost $300 to $400 out of pocket if they try to purchase it. But if you have insurance, then you can always talk to your provider. Either we can get it prior authorization or we can get appeal. So if it gets denied, don't feel disappointed. Your provider can also appeal it, because there is no reason for the insurance company to deny it if you have an epilepsy diagnosis. Every child with epilepsy needs to have rescue medication as long as you are meeting the criteria. So for example, you mentioned about nasal rescue med. So if it's midazolam, if it's Nasilam, it may not be approved if your child is less than 12 years. But if your child is between 6 years and above, the nasal diazepam, which is Valtoco, should be available for you. But the kid is below 6 years, between 2 years and 6 years, the only medication that you have is the rectal diastat. And let's say by if let's say that you don't have insurance coverage, then you always have clonopin available, clonazepam, which is a oral dissolving tablet that's always available for you, and it only costs $10. Yes, so next question is, currently we have clonazepam wafers. Our son is 15. We haven't had to use, but we had it in our hand. So yes, that's a good point, Melissa. Yeah, you can always have clonazepam wafers. Yes, the another question which I have from Diane is, if you have seizures are always shorter than 5 minutes, and if you have never gone into status epilepticus, can you still be approved for rescue medication? Yes. So rescue medications are approved for any patient with epilepsy. You don't have to go into the status epilepticus because that's the treatment for it. I mean, we don't want you to go into the status epilepticus. That's why we have the rescue medication. Sometimes we use 3 minutes. Some physician use 5 minutes. If the seizures are more than 3 minutes, we can administer rescue medication as well. But yes, even if it's a shorter seizure, you need to have a rescue medication.
All right, I was going to give everybody just another second for questions, but it does look like that is all the ones that we have for tonight. So I want to share some of our last slides are, some of our resources that are available. These resources are all available at epilepsyallianceamerica.com. They include a Back to School checklist, a downloadable seizure action plan, rescue medications both in English and in Spanish, which have now been refilmed without masks. Thank you, Lisa and EAA, for getting that done. Trust posters, which I don't think we showed a picture of tonight. These are really, really good. They go over the basic steps of responding to a seizure, and we always recommend giving some to the school to put up or to hand out to anybody who may be able to, or who may need to respond to a seizure. Our on-demand training by Epilepsy Alliance America is also available there as well. And then our list of member organizations. I do really encourage everyone, if you are having any trouble in school navigating any of this, please see if you have a member organization near you that you can call, and they can try to give you some assistance. This is, again, we are Epilepsy Alliance Louisiana. If you need us locally, we are happy to help. And then our final slide is just to thank Neurological, who, through their generous support, made this possible. And with that, y'all, that is our night. Thank you again to all of our presenters for sharing your time and experience. And like I said, please follow up with everyone if you have any questions. All right. Thanks, guys.